Hello everyone, let's try to solve this question together. So a term infant is evaluated for feeding intolerance. Based on the X-ray findings, the next best intervention is to, there are four options given. So this is the bigger picture of the X-ray, and the insert is showing some abnormality. Now let's go back to the question. So what do you guys think is the right answer? Okay, the right choice is obtaining echocardiogram, and let us explore one by one. So obtaining a blood culture, before we do that, what is the abnormality? The abnormality you guys see here is presence of pneumatosis intestinalis. So this is the finding, and so noted, and this is a term infant. Although necrotizing enterocolitis is not that common in term infant, but it can have an early onset. And obtaining a blood culture is a good option, but without antibiotics, there is no role of just obtaining blood culture. So if the option was given to start antibiotics, then this should become a right choice. But with this current thing, only blood culture is not the right answer. Following a KUB is a good option, but 24 hours is a very long interval. We should be following at least 6 to 8 hours to see if this pneumatosis extends or there's a pneumoperitoneum or a risk. And of course, C is right answer. We'll show you why. And obtaining contrast enema is not really needed, especially with this pneumatosis. This doesn't look like a problem with the rectal air or something where you're worried about obstruction or Hirschsprung disease. Now let's go to the slide. So this is the slide which is showing that necrotizing enterocolitis in term infant, and they basically propose that it's entirely a different disease process as compared to preterm infant. So basically here they listed that the congenital heart defect they found in 64%. So that's why getting an echocardiogram is important. The other thing is hyperperfusion. So when you do an echocardiogram, you will get a feeling or the whole dynamic of the heart, and you can evaluate on the hypertension or hyperperfusion as well. And of course, obtaining a blood culture with antibiotics will cover the sepsis part. The next article, which is very interesting, is necrotizing enterocolitis in term infant, and this is a multi-hospital data. And there you guys can found that the congenital heart disease constitute almost 27% of the cases of NEC. And so that's why, looking for an echocardiogram or congenital heart disease by doing an echocardiogram is very important. The second one was polycythemia, and they defined polycythemia with a hematocrit of greater than 70, venous hematocrit. So that is the second one. And of course, sepsis is listed here, and of course, hypertension. And you guys can see here that, sepsis and the use of intraparent antibiotics, they looked at both the thing, and they found sepsis to be significant, but not the use of intrapartum antibiotic. Same thing with the hypertension, they found it significant, but the use of pressors were not significant among the two. Anyway, to conclude, whenever a term infant is found to have necrotizing enterocolitis stage 2 on Bell's criteria, it's very important to monitor for perfusion and getting an echocardiogram to look for cardiac anomalies. Of course, doing a CBC will tell you the infection and the polycythemia, and starting antibiotics should be the thing which we do in necrotizing enterocolitis anyway. So I hope this is a small presentation helps you understanding the pathophysiology and needs for term babies with necrotizing enterocolitis. Necrotizing enterocolitis is still a lot of things are not known. It's a multifactorial thing, and especially in term infants and early onset. I hope you guys have a wonderful day. Bye.